Thanks for coming back and joining us on Public Square. We're joined by our leadership folks, and I wanted to start with you. You were watching most of the discussion. I wanted to know if there's anything in particular that stood out for you.
There were a few things that I heard that weren't entirely accurate.
Talk about that.
It's not, well, and there were several of them, but what I was getting at is I think that is part of a problem, that is an issue, and it's quite frankly because not only is the application process so cumbersome, it's just difficult to understand healthcare, particularly if you're not involved in healthcare.
Let me ask our legislators to chime in.
And so it was very revealing that we've had a silo system of these disjointed programs, which is the main reason that we now have Centennial Care. And it's going to be a huge program.
Is this the Medicaid program for the state?
Well, it's Medicaid, it's long-term care, it's really care coordination. And another area that's being brought into this same waiver is the behavioral health piece, which has been an incredible program, very difficult, lots of problems. And so what we're hoping for is better patient care, better access, and then along with that, the legislature has been working for a long time to try and get ahead of the curve on these problems. All of these things that we're talking about, kids being able to be covered under their parents' insurance, well, we were way ahead of the country in that.
To add to your point, I do think the legislature has been really fairly proactive in especially passing this exchange legislation and passing the exchange legislation in 2011. And I also wanted to talk a little bit more about the Centennial Care application, bringing a lot of these programs together. The state has spent and has applied for federal grants to create an IT system that should be able to help people manage their own Medicaid applications and their children's Medicaid applications much more easily. The difficulty here is that we're now creating an IT platform for our federal marketplace exchange to help people purchase insurance that we're currently spending about $40 million on. And the issue is going to be making these two systems talk to each other so they don't have this silo between Medicaid and the exchange coverage, because there's going to be populations that fluctuate between those two. Because if we're spending upwards of $160 million on these systems, it would be great to have them speak to each other.
Well, we also provided more funding at the state level for more employees at these various offices to help people navigate around, to make the application process more simplistic for people and that sort of thing. So there are big changes. We're going to have a lot of bumps. I'm not understating that problem, but we have really concentrated on it, and I do think that Centennial Care is going to be a better program.
What is the Navigators program? Is that something that's part of this outreach effort?
It will be, and I hope it will be. I think earlier, as you were discussing this whole issue of health reform, I think our work is cut out for us.
Is there going to be money for outreach to get people in Centennial Care?
At this point in time, there's not going to be, and there isn't any money for that. And I guess as chair of the Health and Human Services, I'm a little concerned of how it's going to be received. And if we do get funded, I'm very interested to see how the state is going to implement that.
And the representative is correct. There is this application for the $20 million to do education and outreach. $12 million of that is going to go to advertising about the exchange, and this is all going to go for the exchange enrollment, not Medicaid. And $7 million over 2 years is going to go to in-person assistance and Navigator programs, which the Navigator programs are required by federal law under the Affordable Care Act to help people enroll in coverage. Because I don't know about you guys, but when I was picking a health care plan, and I'm an attorney, I had to have a broker help me figure out how to get health care and where to get it and what the best plan is. And so I think the average person is going to want that as well. And so these in-person assister and Navigator programs are designed to help people learn about insurance coverage, their options. A lot of people, there's not a great amount of health literacy in the state, which is I think something that you were talking about earlier.
Yeah, absolutely. And unfortunately, the Navigators and the personal assisters are going to be hampered in a certain aspect when it comes to assisting those folks that are going out to the exchange, and that they will only be able to assist them in navigating through the actual website. They will be very limited in the information that they can communicate to an applicant about the separate health plans. Now, you
Why?
mentioned because they are to be impartial navigators, assisters. The insurance brokers themselves, however, will be able to give a little bit more information about the actual benefits and the way that the plans within the particular carriers are going to work, unless something has changed.
Here's what the regulation basically says. Navigators have to be fair and impartial, but they can explain the full range of benefits coverage under any given plan. They just can't tell people which plan to pick. They can say, okay, you may have a child with these mental health needs. Here are the plans that have providers in your area for mental health. They can provide a substantial amount of information. I do think brokers are going to be very essential in the system, and I do sort of have been advocating for the state to think about having brokers that work with navigators and in-person assisters. So if there are situations that the navigators or in-person assisters can't handle, there's a very warm handoff to a broker who could help in those situations.
But does this get to the issue of Medicaid outreach? Because what about the people who?
No.
Okay.
No.
So we don't have state funding for Medicaid outreach, but we do have a lot of funding for the exchange that's coming from the federal government to do outreach. And the decision that the exchange has to make right now is whether they use that money for Medicaid outreach as well. It would be a smart choice for the state to do both of those things together, to outreach on Medicaid and the exchange, because quite frankly, many families have members who are going to be on both. You know, Michaela is an example, so you might have your child on Medicaid, but you yourself might be getting exchange coverage, and so of course you would want to be educated about all of the options.
We have always had a problem getting children into the system. In fact, we had so much money left over from our S-CHIP program a few years back, which was the Children's
Health
Insurance program. But there was so much money that we were going to lose. That's how we got into the SCI program, which was the program for low-income adults that were over the level of poverty.
What Michaela
And we had school-based health clinics that we funded, an expansion of that. Still couldn't get the children in. It's not that we haven't been trying. It's just a continual issue. I obviously am not going to be surprised if we don't have all of the numbers in the system, especially the first couple years, because we've been trying every which way to get especially children.
But apparently we're also
into the
losing
system.
children who've been enrolled off the rolls, right?
So we are losing children who've been enrolled, and it goes back to the exact problem that Michaela was talking about before. There's a number of barriers, but one of the big ones is that newborn children, right? After 1 year of being on Medicaid, you would think that what would happen is that they would just renew and get back onto Medicaid again, because they've already proven their citizenship, residency, and all these pieces, and in fact, under federal law, you're not supposed to have to prove those pieces again, but our state does make people prove those again. They make people come back in for an entirely new application. This is an issue that the Center on Law and Poverty has taken up with the Human Services Department. We haven't gotten a response from them, and we actually had to file a motion in a lawsuit to be able to get compliance on this issue.
Unfortunately, the Human Services Department could not be with us on this particular taping, so I can't ask them to address that. I don't know if that's something that could be fixed legislatively.
Process is so cumbersome. 40,000 that qualify for Medicaid that don't take advantage of it. It's not for lack of trying on everyone's part to get those kids covered. Part of it is that it's cumbersome. There are a number of issues.
So what could change? How could that be better?
Well, it's not the only reason. That's just part of the reason, is that it's the application process is cumbersome. The fact that a lot of people don't know they qualify. Well, I'm working. I'm not going to qualify. Well, that doesn't preclude you from Medicaid. And unfortunately, still, there is a stigma. I'm not going to take that. I'm working. I'm going to provide for my family.
You agree with that, Lily?
Oh, I do absolutely. I mean, I've transitioning into college. My son was born the second semester, and a few of my friends just decided to stop talking to me because I took on the opportunity of Medicaid. And I feel that out here, we're in New Mexico, in the United States, we're very privileged to have that, and it is a stigma within society.
So should the expansion of Medicaid be a goal? Is that the best way to do some of this? Or
Well, not that it's a goal, but I think it's something that if you qualify, we should be aware of it, and it shouldn't be something that is shamed on.
The norm has been that people go without health insurance and health coverage. And so we've got to flip that idea first, that first everyone deserves health care and that there are ways to get help to get there.
There is some misinformation out there that people think they're getting less quality if they're on Medicare or Medicaid. And I think that that's another piece that needs to be clarified, that the quality isn't necessarily less because you're private pay, or better if it's private pay.
I know at the Pueblo of Laguna we're working on a coverage campaign, and it's really designed to encourage people to take advantage of these new coverage options, but also to eliminate the stigma associated with publicly financed coverage. And what's interesting, there's no stigma around Medicare except that you're getting older. You know, it's
like getting your ARP card.
But one of the things that we're doing is, just coming up with kind of fun slogans, and then getting local community members and leaders to share their stories about how Medicaid has really improved their access or improved their families' lives, so people can really see that lots of folks are entitled to this program. And I think that's the key, entitled. And I think you hit on this earlier, Micaela. When you go to the ISD office, you're entitled to be there. You have a right to go and apply for this coverage. We're all paying into this system, and we need to make sure that people who are eligible for the program are able to access it.
Representative Madalena, you were going to say.
It's hard to perhaps have the normal person accept something that is being offered from the state level. And it's only because of historical experiences, so to speak, and that lack of trust is there.
Of course, my goal is to have better health care for people of low income, in hopes that their goal is going to be to transition into private insurance. We did expand the level of poverty to 138% of poverty for Medicaid, and part of what we're hoping is that if people can have better prenatal health care and have healthier babies, and then we have in-home visiting that we continue to put more money in every year, and that is an income-based program. That we'll have healthier children, that along with better education and reforms that the state is going to pull itself up from poverty. I'm also worried about the private insurance and having more people dumped into the exchange because the increased costs. And so, all of these things are making it extremely perplexing right now that I am, along with many of my colleagues, challenging the state to really move out of poverty.
But will moving more people from Medicaid to private insurance necessarily accomplish that? It seems unclear.
What the Affordable Care Act does in conjunction with Medicaid expansion runs up to, as she said, 138% of the federal poverty level. People then that make just above that 139 up to 400%, which for a single individual is $42,700 a year, will be eligible to receive an advanced subsidy toward the purchase of their health care.
From the federal government.
From the federal government. Both the Commercial Affordable Care Act and Medicaid, one of the main focuses on both those types of coverage is that wellness and prevention, which ultimately is designed to help stem the cost of health care, because prenatal care, you get the kids treated early, you get the expectant mothers covered so that they don't have the difficult delivery for which they have to pay for themselves. The child is more healthy. Getting preventive care and early child care and wellness even for adults, you can keep the population healthier earlier without them then having the large claim of an expensive medical procedure.
I will say this still sounds like it's going to be very complicated.
Yes.
As a consumer, I'm just
like it.
saying.
There's still going to be a problem.
Being the family, right, who walks in and hears an advertisement that there's this new coverage available, and they have no clue what they might or might not qualify for. What you want to happen, what I hope happens, is that someone from the exchange, one of these assisters, would be able to say, oh, you make this much, your family is this big, you probably qualify for Medicaid. But if they have to send them to another office and go fill out a different application and go talk to someone else, what's the likelihood that people will follow through take a day, take more time to go figure that out. Why not use this resource that's being available through the exchange to help people get covered no matter what? It's called the no wrong door policy, and it's like, let's just help people exactly where they're at.
The no wrong door policy of the Affordable Care Act basically says that no matter what you qualify for, you shouldn't have to go to 12 different doors to find it. I do think that there's an issue of siloing of some of these programs, and they're trying to bring some of these programs together through the Centennial Care Waiver, but also an issue that could potentially be happening in the future with the development of two different IT systems, the Navigator and In-Person Assister system, which is only geared towards helping people out with exchange coverage. I would advocate that these people should also be able to help people out in applying for Medicaid, so that people aren't taking another day off of work, potentially losing their job, just to get Medicaid coverage, or vice versa. They go to the ISD office, wait there all day, learn they're not qualified, and then have to go to an In-Person Assister or Navigator to get exchange coverage. So the no wrong door policy, and in other states the way it's been implemented, is that you go to one of these people and they're trained in any of these programs so that they can help the people get enrolled.
Lower administrative costs.
Yeah.
So like when she timed out of that one program, to know that she still has a child, the income hasn't changed, that you automatically would go into this.
So are you saying they should put more, there should be more resources put towards these kind of in-person people, assisters, navigators?
And integration of the
figure this
system so
out.
that they're not siloed, as the senator was saying.
Can I offer something that, for me, I'm hearing that connects some of these conversations? So going back to what some of the stigma and shame is around accessing care, I think it's really important to talk about where that comes from, and how in many ways that comes from the systems itself and those you're supposed to be connecting with in order to get the care for your family that your family needs. So when systems are designed to catch the crooks or to catch the people out there that are trying to scam for $1, hardworking families like Lily and I have to jump through hoop after hoop after hoop to get basic care. And that's not getting anybody's family healthier or out of poverty. What if instead those resources were invested in somebody that I could have a half-an-hour conversation with to make sure that I was going to the right places and doing what I needed to do and providing the right information? And currently the Medicaid applications actually offer information or provide directions that are inaccurate. So when I think about what our state needs so that families like mine that are working hard, being responsible, can have stability and well-being, I say, is our state really invested in providing access to health care or not? And if you really want families to do well, are we investing in early childhood education? Are we investing in living wage jobs? Are we investing in childcare? Because those are the markers that allow me to go work and advance my career and keep paying for what I do. But if I don't have those things, I've had to make decisions. Do I have somewhere safe to take my kid to leave them in childcare that I can afford? Because if not, I'm going to have to work less, which means that I'm still relying on some state systems. But if there was childcare,
This young lady, it's almost like she's looking into the descriptions of what Centennial Care is and some of the way that we have crafted our budgets. One of the pillars of this Centennial Care program is patient care coordinators, to take a young lady like this and help her get through the right program that they have not had in the past. So
Is this the same as the Navigator?
no. Yeah, this is the Centennial. That's why all these waivers with disjointed programs and different approach contacts and that sort of thing. This is a much better system. I was skeptical at the beginning, mainly because of the behavioral health piece and the cost of that. But now I see that when you have a whole system where you integrate all of these programs together, you're going to see a better outcome.
You don't think there's enough money allocated for these in-person? You think that's the most effective way?
I do think that that's the most effective way. Ad campaigns, get people familiar with the concept of what's happening with healthcare reform and Medicaid expansion. But something needs to motivate you to actually sit down and enroll in coverage. And national studies by Enroll America and some other national organizations have shown that what people want to get enrolled in healthcare coverage is in-person personal assistance. The funding for this right now is fairly minimal compared to, I think, the need for in-person assistance programs, given the number of uninsured we have in New Mexico and the number of people that are going to need to go to the exchange. We have about 200,000 people
So is it
uninsured.
federal funding?
There are two sources of funding. Navigators are funded through state funding in the exchange, and the legislature needs to figure out how they're going to provide state funding to this Navigator program. That hasn't been decided yet, and we don't have funding for Navigators in the first year of the insurance marketplace.
That seems important.
Yeah, and so we don't have funding for that. What we have currently is federal funding through this $20 million grant, the $7 million for 2 years, $3 million to get people on the ground out there in the communities that are harder to reach. We know from statistics, especially statistics showing children's insurance coverage, that areas in the northwest corner of the state and the southern corners of the state are particularly in need of resources to help people get enrolled. But we're not dedicating the resources and requesting the amount of federal funding that I would advocate that we need to get people enrolled in coverage and sit down with people for this half-hour conversation. I do think there needs to be some consistency and quality control, and I'm not entirely sure how that's done, and I'm not entirely sure what the legislature's oversight of that is.
What do we need to do now to ensure that more kids are covered in New Mexico?
So I think there are 3 basic things that need to be done. One is outreach. We know that the children who aren't getting covered in New Mexico are the ones who are hardest to reach right now. Native Americans disproportionately make up those kids who are not covered. Citizen kids who are in immigrant families also make up the children who are not covered. And so outreach is incredibly important. The second thing that I think we have to do is we have to simplify the program. For example, we could do something called Express Lane enrollment, where we look at all the children who are on SNAP, for example, the food stamps program, and make sure every single child on food stamps is also getting Medicaid. That's not the case right now. There are thousands of kids who get SNAP who aren't on Medicaid, and the state could easily just enroll them. And then I think the third thing is that I think as a community and as lawmakers and as advocates, we have to have a commitment to getting every single child enrolled into Medicaid and getting every single person enrolled into health care. That would be huge, to commit schools to helping ensure every kid in that school is enrolled, to have churches, commit to having everybody in the church enrolled. Everybody can be involved in something like that to get every single person health care. And from our legislators and from lawmakers to also make that commitment to have 100% enrollment to get the state funding, for outreach. Because right now that's part of the problem is that, the Human Services Department is saying that this is how they want to save money is by pulling back on outreach, by pulling back on enrollment, and the damage is being done to our children.
Families like mine aren't actually asking for help. What we're asking for is clear and accurate information, and then a system, an efficient process that has clear entry points and clear accountability and transparency so that we can stay engaged in healthcare and make the right decisions for our families.
I'm going to give Michaela the last word.
Yeah, that's great.
Thank you very much. I appreciate you all coming to talk about this.